online anesthesia video of this week. You can also participate in this program if you are interested. Just record your video presentation on Zoom platform and send to us in onlineanesthesia@gmail.com. For further rules and regulations, please visit our FB page online anesthesia. Let us watch this week's video.
Good morning to everyone. I am Dr. Shanmugam, Critical Care Medicine Consultant from Meenakshi Hospital, Madurai. Today we have academic session on EFAST, Extended Focused Assessment with Sonography and Trauma, and I wish to keep this class as simple as practical. In this class we are going to see some slides on origin of FAST and EFAST, indications and limitations of EFAST, the patient and machine preparation, the EFAST algorithm, and how to do the EFAST assessment step by step, and there are some notes on serial FAST and importance of doing FAST in pregnant patients. The traumatic injury is the leading cause of death in up to 45-year age group patients. The extended focus assessment with sonography for trauma, which is commonly abbreviated as EFAST, is a rapid screening tool for injury at the bedside with the help of ultrasound, with the main goal of detecting hemoperitoneum, hemopericardium, and hemopneumothorax in trauma patients. Because in trauma patients, the presence of free fluid in the peritoneal cavity or pericardial cavity or pleural cavity assumed to be blood unless proved otherwise. So, the identification of free fluid within the peritoneal cavity or pericardial cavity or pleural cavity with the help of EFAST will give enormous data to the emergency physicians or surgeons so they can plan the next step of management as early as possible. And being fast is the best assessment. This will be very much useful in hemodynamically unstable patients because it will be avoiding the complication associated with shifting of hemodynamically unstable patient to the C tissue. Prior to the advent of FAST, invasive procedures like diagnostic peritoneal lavage and exploratory laparotomy were commonly done to diagnose the intra-abdominal injury. In 1993, Dr. Rosicki introduced the original FAST assessment to rule out bleeding in abdomen and pericardial cavity. The original FAST assessment has 4 views that includes pericardial view, right upper quadrant view, left upper quadrant view, and pelvic view. Since that the FAST assessment has been extensively utilized and studied in both blunt and penetrating trauma patients, and there have been many variations in technique and protocol and interpretation have been introduced. This is the original research article published by Dr. Grace Rosicki in 1993. This is the first research article on FAST assessment and algorithm. 5 years later, Dr. Rosicki published another research on FAST assessment on the large set of patients. His reports are: the FAST assessment has sensitivity of 83.3% and specificity of 99.7% in detecting injuries in precordial and abdominal trauma. So he concluded the ultrasound should be the initial diagnostic modality for the evaluation of patients with precordial wound and blunt trauma wounds because the ultrasound is rapid and accurate. In 2004, Dr. Kirkpatrick introduced the EFAST assessment. In the EFAST assessment, he added lung ultrasound in addition to existing FAST examination of abdomen and heart. This is because of several studies that published in the late 90s and early 2000s those demonstrated the effectiveness of ultrasound in detecting the pneumothorax. So the current EFAST exams consist of ultrasound evaluation of abdomen, heart, and lungs. This is the original EFAST article that was published by Dr. Kirkpatrick in 2004. You can see he did the lung ultrasound examination with the help of high-frequency linear transducer, and he compared the results of EFAST exams with the chest X-ray, and his results showed that EFAST has higher sensitivity over chest X-ray in detecting the pneumothorax, and it has high specificity too. Coming to the indications and limitations. The EFAST is the best bedside injury screening tool in trauma patients. It is indicated in hemodynamically unstable trauma patients. Both abdominal and thoracic trauma with either blunt or penetrating trauma wounds are indicated for E-fast assessment. The E-fast assessment also indicated in previously stable trauma patient with acute worsening in clinical status. The limiting factors are the E-fast assessment is only 85% sensitive even with experienced hand. So there are high chances of false negative cases, and the false negativity become much higher when we do the E-fast assessment in clinically stable patients. And positive fast assessment requires at least more than 150 ml of fluid in the peritoneal cavity. So other limiting factors are, even though we can detect the free fluid with the help of E-fast assessment, it does not localize the injured abdominal organ. Views may be limited in patient with subcutaneous emphysema, and views may be limited with patient with hollow viscous injury which cause free wear in the abdomen or pneumoperitoneum. Coming to the patient and machine preparation. We do the fast assessment while the patient is lying supine with either flat position or tunnel position. We commonly use paced array or cardiac probe, so entire fast examination can be done with single probe. We can also use curvilinear probe, but it will be very difficult to obtain the cardiac waves with the curvilinear probe. So if we are right-handed person, keep the machine, ultrasound machine in the right side of the patient and scan the patient with your right hand and operate the machine with your left hand. What is the recommended E-fast sequence? There are many different sequences of E-fast available. In the original fast assessment, which was done by Dr. Rosicki, in which he started the assessment with the pericardial view, followed by right upper quadrant view, then left upper quadrant view, then ended with pelvic view. Currently, many emergency physicians do the E-fast by beginning from right upper quadrant view, then left upper quadrant view, then pelvic view, then move to pericardial view, finally end with the lungs view. So choose whatever sequence that's work for you and perform it in the same way each time. The next will be step-by-step assessment of E-fast views. Here we are going to see all 5 normal views of E-fast. First we will be seeing normal view, then we will be seeing abnormal slides. So first we will be seeing right upper quadrant view. The liver is the most commonly injured organ in blunt trauma abdomen. The right upper quadrant view is the most sensitive view of E-fast assessment to detect the free fluid. So what are the structures in the right upper quadrant view? Here we can see the diaphragm. Above the diaphragm we have the right lung. Below the diaphragm we have the liver, and here we can see the right kidney. The space between the liver and right kidney is called Morrison's pouch. So to get the right upper quadrant view in the ultrasound, just place the ultrasound probe in the mid-axillary line around the 10th intercostal space, and by using liver as the acoustic window, we can see the following structures. Here the bright structure is the diaphragm, and above the diaphragm we have the lung, below the diaphragm we have the liver, and we can see the long axis of the kidney, and there is a space between the liver and the right kidney, which is Morrison's pouch. So look for the free fluid both above the diaphragm, that is hemothorax, or below the diaphragm, that is hemoperitoneum. In right upper quadrant view, the fluid gets collected most commonly in the Morrison's pouch, that is the space between liver and the right kidney. Apart from Morrison's pouch, we can also see the fluid collection just below the diaphragm in the suprahepatic space or above around the caudal lobe of the liver. Next, we have the left upper quadrant view. The left upper quadrant view is the least sensitive view of the E-fast assessment to detect the free fluid. So what are the structures that's present in the left upper quadrant view? Here we can see this is a diaphragm. Above the diaphragm is the lung, left lung, and below the diaphragm we have the spleen, and below the spleen we have the left kidney. There is a space between the diaphragm and the spleen that is called subphrenic space. Compared to the right kidney, the left kidney is placed more posteriorly and capillarly. So to get the left upper quadrant view, we need to place the ultrasound probe more posteriorly in the posterior axillary line at the 8th or 9th intercostal space. So here we can see by using the spleen as the acoustic window, we can see the following structure. This is the diaphragm. Above the diaphragm, we have the lung, left lung. Below the diaphragm, we have the spleen. And here we can see the left kidney in a longitudinal axis. And this is the space just below the diaphragm. It's called subphrenic space or perisplenic space. The free fluid in the left upper quadrant most commonly seen in perisplenic space or subphrenic space. This is in contrast to right upper quadrant view, where we most commonly see the free fluid in the Morrison pore, that is between the liver and the right kidney. Here, most often the free fluid is collected in the perisplenic space. Because the presence of splenorenal ligament that limit the ability of fluid to track between the kidney, left kidney and the spleen, the fluid accumulation most often won't be here. The next is pelvic view or suprapubic view. So before reading about the pelvic view, we should remember some important points. Always try to scan the patient with full bladder because the urinary bladder can be used as acoustic window. So try to initiate the EFA scan prior to Foley catheter placement. Second, consider the gender of your patient before doing the pelvic scan because tendency of free fluid accumulation in different locations depends upon the gender of patients. In male, we can have the free fluid accumulation in rectovesical pouch. In female, the free fluid can be seen in vesicouterine pouch and rectouterine pouch. Third thing we need to remember is it is normal to have very minimal or some amount of physiological fluid in the rectouterine pouch or pouch of Douglas in females. So with this, how to do the pelvic view? So to do the pelvic view or suprapubic view, just keep the ultrasound probe in the midline right above the pubic symphysis and point out the ultrasound probe towards the pelvic cavity. So we can see the following structures here. Based on the gender of the patient, the structures will be different. So we will be seeing those in next slides. So here we are going to see the male pelvis structures. The anteriormost structure is the urinary bladder, and you can see the prostate around the neck of the urinary bladder, and posterior to the bladder you can see the seminal vesicle and some part of prostate, and posterior to this you can see the rectum. The space between the bladder and the rectum is called rectovesical pouch or rectovesicular space. In the ultrasound image also we can see the same structure. This is a completely anechoic structure. This is urinary bladder, and posterior to the urinary bladder you can see the hypoechoic structure, that is prostate, and posterior to the prostate this is the rectum. So the space that is between the bladder and the rectum is called rectovesicular space. So in males, the free fluid usually accumulate in the rectovesicular space. So here we can see the transverse image of the same. This is a completely anechoic structure. This is urinary bladder, and posterior to the urinary bladder we have the prostate, and posterior to the prostate we have the rectum. So this is the space between the urinary bladder and rectum. So this is the rectovesicular space. We can see the fluid accumulation here in the pathological condition. So here also another picture of male pelvis, the sagittal view. So we can see the completely anechoic structure, that is the urinary bladder. Posterior to urinary bladder we have the prostate, and posterior to the prostate this is the rectum. This is the seminal vesicle, this is the rectum, and we can see the rectovesicular pouch here. So See here again the transverse image. This is the urinary bladder, this is the prostate, and this is the rectum. Just above this space is called rectovesicular pouch. So here we can see the structures of female pelvis. The anteriormost structure is the urinary bladder. The posterior to the urinary bladder we can see the anteverted uterus, and posterior to the uterus we can see the rectum. So the space between the urinary bladder and the uterus is called vesico-uterine pouch, and the space between the uterus and rectum is called recto-uterine pouch or pouch of Douglas. So pouch of Douglas is the space in the female pelvis. We can commonly see in the free fluid. Here in the ultrasound image, we can see the completely anechoic structure. There is the urinary bladder, and posterior to the urinary bladder, we can see the uterus, and posterior to the uterus, we can see the rectum. Okay. Here we can say there is no free fluid collection between the uterus and rectum. There are small dot of anechoic structure is seen. This could be normal physiological fluid in the pouch of Douglas. So here, this transverse image, we can see the completely anechoic structure, that is urinary bladder, and posterior to the urinary bladder we have the uterus, and posterior to the uterus we have the rectum. And here also we can say there is no free fluid is present between the uterus and rectum, that is the pouch of Douglas. So again, another transverse and longitudinal pictures of female pelvis. So in the transverse picture, you can see this is the urinary bladder, completely anechoic structure, and posterior to the urinary bladder, we can see the uterus, which is the isoechoic structure, and posterior to the uterus, there is the rectum, and there is no fluid collection between the uterus and the rectum. Here in the longitudinal plane, this is the urinary bladder, completely anechoic structure. Posterior to the bladder, we can see the isoechoic structure, which is uterus, and posterior to the uterus, we can see the rectum. Here also, we can clearly see there is no free fluid collection. So next, we are going to study the cardiac view of EFAST. Here, we are going to assess whether the patient is having pericardial effusion with cardiac tamponade. The subspecified view is the most preferred view to assess the presence of any pericardial fluid. So, if the subspecified view cannot be obtained, we can use the parasternal long-axis view to look for any pericardial fluid. So, how to obtain the subspecified view? Place the echo probe below the cephisternum. Make sure the pointer facing towards the spleen or left side of the patient. Press the probe into the patient abdomen while tilting the tail of the probe towards the patient's right leg. By using the liver as an acoustic window, we can identify the following structures. So this is the subspecified view structures. You can see the liver, and this is the pericardium, and you can see the right ventricle, right atrium, and left ventricle. And you can see there is some fluid collection around the surface of the right atrium and the right ventricle below the pericardium. This could be pericardial effusion. So next view we have is lung view of EFAST. In EFAST, we use the lung view to rule out or confirm the pneumothorax. So we know the parietal flora covers the surface of the thorax, and the visceral flora covers the surface of the lung. So when we take breath and when the patient takes breath, both the flora move against each other, and this makes sliding movement in the ultrasound. Okay, and this sliding movement can be easily assessed in the anterior aspect of the lung, in the mid-clavicular line, about second ventricle space or third ventricle space, which is the most sensitive spot. We have to look for pneumothorax. So this is a small video clip on normal lung ultrasound. So we can know the structures here. This is skin, subcutaneous tissue, small muscle. This is a rib, and this is also a rib. Below the rib there is a rib shadow. Here also below the rib is a dark rib shadow. And between the ribs, you can see the bright structure that is pleura. Below the pleura, this is the lung parenchyma. In the last slide, we saw when the parietal pleura and visceral pleura moves against each other, that will cause sliding movement. So you can see the sliding movement in the pleura. The sliding movement appears like a ant marching over the rope. So you can see the bright structure, and in the bright structure you can see the ant marching over the rope like movement. So this is normal lung ultrasound. So when we put the motion mode across the lung parenchyma, across the here, if you place the motion mode here, so when we apply the M mode in normal lung ultrasound, we will be getting this picture. So this is the bright line that is pleura. And above the pleura, the structures are not moving, which is skin, subcutaneous tissue, or intercostal muscle. Below the pleura, there is a lung parenchyma. So this area has movement, this area does not have movement. So we can easily differentiate the two structures below and above the pleura. This is called seashore sign. So why it is called seashore sign? So we can see the aerated lung here appears to be the sand of the beach, and above that you can see the pleura and you can see the non-movable structures here. So this appears to be the wave of the sea. So the entire picture appears like sea and the beach. So this is called seashore sign. So as a summary, we should know these two things in the lung assessment of EFAST. First, identify the lung sliding, look for the ant marching sign, and apply the M mode, get the seashore sign. So apart from the pleural sliding and seashore sign, we should know about two important lines in lung ultrasound assessment. These are A lines and B lines. What is A line? The A lines are horizontal hyperechoic lines. These are repetitive reflection of ultrasound waves between the pleural line and the transducer. So these are actually equidistant repetition of pleural lines. So we can see the A lines in absolutely normal aerated lung. And this kind of reverberation pattern of A line is not just specific to the lung. Any strong reflector or air in the body can produce this kind of reverberation artifacts. So what are B lines? So B lines are ray-like hyperechoic vertical discrete structure that begins from the pleura and goes to infinity. These lines moves along with the lung sliding, and this obliterates the A lines at the point of intersection. And why the B lines happen? The B lines happen because of presence of fluid in the either alveoli or in the interstitial spaces. Presence of 3 or more B lines in the single rib space is considered to be abnormal, and presence of pleural sliding along with the B lines literally rules out the pneumothorax. So let us move into pathology. Here we are going to see examples for all 5 views of EFAST positive. I already said, in trauma patients, the presence of free fluid in parietal cavity or pericardial cavity or in the pleural cavity are assumed to be bad unless proven otherwise. So, the presence of free fluid in the right upper quadrant or on the left upper quadrant are assumed to be hemoperitoneum unless proven otherwise. Let's move into the right upper quadrant view. In the right upper quadrant view, there are 3 common locations for the free fluid to accumulate. The first space is the space between the liver and the kidney, which is called Morrison's pouch. The second space is just above the liver and below the diaphragm, which is the suprahepatic space. The third space is around the caudal lobe of the liver. So we will be seeing the example for each. So you can see the liver and the right kidney is separated by the completely anechoic structure. This is the free fluid present in the right upper quadrant. So we can see the free fluid collection in the Morrison's pouch and around the caudal lobe of the liver. Here in this picture also we can see the free fluid collection between the liver and the right kidney, which is the Morrison's pouch. here also we can see the free fluid accumulation in the suprahepatic space. So let's see another example for right upper quadrant fluid collection. So this is the completely normal picture of right upper quadrant view. So here we can see the diaphragm, and this is the liver, and there is no free fluid in the suprahepatic space, and this is the Morrison's pouch between the liver and the right kidney. There is no free fluid collection, and there is no free fluid collection around the caudal lobe of the liver also. But in the abnormal picture, we can easily say there is free fluid collection around the caudal lobe of the liver, and there is a free fluid collection between the liver and the right kidney. So this is the Morrison's pouch. So we can say the patient is E first positive. So patient may have the hemoperitoneum. So moving to the left upper quadrant view. So in left upper quadrant view, we have to check for the free fluid in the three spaces. One is the perisplenic space, the space just below the diaphragm or above the spleen. This space also called subphrenic space. And second, the space around the tip of the spleen. Third space is the splenorenal recess. I already told in the left upper quadrant view, the fluid collection most commonly seen in the perisplenic space, because there is the presence of splenorenal ligament here, and this will restrict the ability of fluid to get trapped here. So the most common area to find the free fluid in this left upper quadrant will be perisplenic space. So now we will be seeing the examples. So now we can see this is the perisplenic phase, and there is the fluid collection in the perisplenic phase, and there is the fluid collection also in the around the spleen tip. So we can easily see the fluid collection around the fluid tip and in the perisplenic phase, and there are some minimal collection between in the splenorenal recess. So we have another one example. This is the completely normal left upper quadrant image. Let's see here. There is the diaphragm, and this is spleen, and there is no free fluid collection in the perisplenic phase or around the tip of the spleen, and the splenorenal recess is also literally free of fluid. But here we can see there is a fluid collection in the perisplenic space and around the tip of the spleen, and there is some fluid collection here also in the splenorenal space. Moving into the pelvic view or suprapubic view in male pelvis. So I think we remember the structures. This is the anteromal structure, which is urinary bladder, and we can see the prostate around the neck of the bladder, and posterior to the bladder there are some part of the prostate and seminal vesicles are there, and posterior to this there is a rectum. So the space between the bladder and the rectum is called rectovesical pouch, which is the most common area in male for the fluid accumulation. So you can see the same image in the ultrasound. This is the urinary bladder, completely anechoic structure, and here there is a rectum. So the space between the rectum and the bladder is called the rectovesical pouch. So here we are going to see the example for fast positive male pelvis. So this is a longitudinal view and it's a transverse view. In the longitudinal view, we can see the structure. This is the urinary bladder, completely anechoic structure, and this is the rectum. And we can see the fluid collection between the bladder and the rectum, that is rectovesical pouch. Here also, we can see the urinary bladder, and posterior to the urinary bladder we have the prostate, and posterior to the prostate we have the rectum. So there is the fluid collection between the bladder and the rectum in the rectovesical pouch. So this patient is E first positive. So here we are going to see the suprapubic view of female pelvis. You know the structure. This is the urinary bladder, and it's the uterus, the rectum, and this is the vesicouterine pouch, and it's the rectouterine pouch or pouch of Douglas. So this is the same view in the ultrasound. You can see the completely anechoic structure. This is the urinary bladder. Posterior to the urinary bladder is the uterus, and posterior to the uterus there is the rectum. This is a small amount of anaerobic structure is there. This could be considered as a physiological free fluid in the pouch of Douglas. So it is difficult to differentiate the physiological free fluid or pathological free fluid in the pouch of Douglas without knowing the patient's clinical condition. So here we have another longitudinal view of the ultrasound. Here we can see the completely anaerobic structure is the urinary bladder. This is the antevated uterus, and below the uterus you have the rectum, and this is the rectouterine pouch. Here we can say there is no free fluid collection. But here in the another same image, this is the urinary bladder and it's the uterus, and here you can see the fluid collection in the rectouterine pouch or pouch of Douglas. Here we have the example of pathological fluid collection in the pouch of Douglas. So both the images are suprapubic view of female pelvis. So here you can see the transverse view. This is the bladder. The posterior to the bladder, this is the uterus, and posterior to this is the rectum. And you can see the huge long fluid collection between the uterus and the rectum. Here also in the longitudinal view, you can see the fluid collection that is present in the multiple locations over the length of the uterus. This is not limited to single space like the images we saw before. Here also we can see the fluid collection between the uterus and the urinary bladder. So this patient is E-fast positive at the suprapubic view. Coming to the pericardial effusion and cardiac tamponade. Any fluid accumulation in pericardial sac called as pericardial effusion. The presence of pericardial effusion does not mean that the patient is having cardiac tamponade. The pericardial fluid must impair the cardiac filling to cause the tamponade effect. So consider cardiac tamponade only if there is systolic right atrial collapse, which is the most sensitive sign for the cardiac tamponade, or diastolic right ventricular collapse, which is the most specific sign for the cardiac tamponade. So here we can see two images, both are subsequent echo view. In this subsequent echo view, you can see the structure. This is the liver and this is the pericardium, and we can see there is a huge pericardial effusion. The collapsed right ventricle, the right atrium, is the left atrium, and the left ventricle. Here you can see the right ventricle is completely collapsed because of the pericardial effusion. So we can say the patient is having cardiac tamponade. Here we can see the structures. This is the pericardium, and this is the massive pericardial effusion, and you can see the right ventricle, right atrium, left ventricle, and you can see both the right atrium and right ventricle are collapsing. But how to check whether the right ventricle is collapsing during diastole or systole? So to check that, just to freeze the echo scan and trace the timeline for the mitral valve opening. And if we say trace the timeline for the mitral valve opening and followed by left ventricle diastole, and the left ventricle diastole correlated with the right ventricle diastole. So we can easily say whether the collapse is happening during the systole or diastole. Coming to the pneumothorax, we have already seen what is lung sliding, what is seizure sign, what are V lines and E lines. In lung ultrasound, the presence of sliding along with the V lines typically rules out the pneumothorax. But the absence of lung sliding also seen in multiple conditions like severe consolidation, severe ARDS, mainstem intubation, chemical fluorodesis, and some fibrotic diseases. So, in absence of lung sliding, look for two important signs. One is barcode sign, another one is a lung point. Here in the lung scan, we can see there is no lung sliding at all. Okay. There is no lung sliding at the pleural line, and there are no V lines too. And if we apply the motion mode here, M mode here, we can see multiple straight horizontal lines over the time instead of having the seesaw sign. This appears like a barcode, so this is called as the barcode sign. This barcode sign is commonly seen in pneumothorax. So if we get the barcode sign, the next step will be looking for the lung point. So what is lung point? Lung point is at which the visceral flora begins to separate from the parietal flora at the margin of the pneumothorax. So here you can see at this point, one side we will be having well aerated lung with sliding flora. Another side we have motionless collapsed lung without the sliding flora. So the lung point is a border between collapsed lung and the aerated lung. E-fast algorithm. Why do we need algorithm? We know the E-fast helps us to identify the region of bleeding in trauma patients. But we also need to remember there are 50% of false negative reports with the E-fast assessment and the false negative reports much higher when the patient is clinically stable. The negative initial fast exam in patient with high suspicious mechanism of injury warrant further CT scan evaluation or serial fast exam, especially in setting of worsening clinical status. This can be either worsening vitals, hemodynamic instability, worsening pains, or increasing the abdomen distension. Some patients may also have delayed presentation. So the algorithm is made not to miss the two positive cases of trauma. So when the trauma patient arrives ED, if the patient is clinically unstable, we will be doing the fast exam, and if the fast exam becomes positive, the patient will be shifted to the operating room for damage control surgery. And if the fast exam becomes negative, but the patient has high suspicious mechanism of injury, the patient will be shifted to the CT room for the further evaluation. In clinically stable patient, if fast becomes stable, the patient may give further time, so we can go for a CT scan evaluation and do the further management. And if the fast exam becomes negative and the patient still have the high suspicious mechanism of injury, the patient will be further evaluated by serial fast exam and or CT scan or by clinical observation. Serial fast assessment. The initial fast is just like a snapshot at the time of arrival to the ER. The serial fast examination will be very helpful in stable trauma patient. The active intraperitoneal hemorrhage, the amount of free fluid should be theoretically increased over the time. So the serial fast exam assessments decrease the false negative rate by 50%, and it also increase the sensitivity for the free fluid detection from 69 to 89%. Fast in pregnant patient. The trauma accounts for 7% of maternal mortality. The fetal loss also more common with abdominal trauma. Many obstetric complications occurs when the trauma happens in third trimester. The fast assessment in the pregnant patient has similar sensitivity and specificity as in non-pregnant patients. The placenta examination is very important in case of maternal fast examination. The presence of placental abruption with negative or equivocal fast exam requires continuous CTG monitors for the fetus, and the fetal cardiac activity also must check with the MR. The fetus should be examined for other injuries which sustained during impact to the maternal abdomen. Accuracy of fast assessment. The sensitivity of fast exams ranges from 69 to 98%. The specificity ranges from 95 to 100%. These are high values because these are the data from the initial studies in which the fast exam was compared with the patient outcome, not with the CT scan outcome. So in later studies, when we compare the fast assessment outcome with the CT scan outcome, we had high false negative case in clinically stable trauma patient. The sensitivity dropped up to 22% in clinically stable patient. So the negative fast study without follow-up CT scan may miss many intra-abdominal injuries. So the take-home point here is, whenever we do the E-fast assessment, we should consider the current clinical status of the patient, the mechanism of injury, any change in the clinical examination or hemodynamic status, or decision on further diagnostic testing with the initial negative fast scan. And the fast exam also included the ATLS protocol since 1997, and the fast reduced the need of diagnostic peritoneal lavage from 9% to 1% over the years. Thank you.